Hi, welcome everyone. Welcome to the next quarterly Parkinson's webinar brought to you by Cure Parkinson's, the Journal of Parkinson's Disease, and the University of Edinburgh. So my name is Professor Thilo Kunath. I'm sitting in the Center for Regenerative Medicine in Edinburgh, Scotland. And today we're going to have an exciting webinar looking at inflammation and Parkinson's disease. And we have three brilliant guests that I'm going to let them self-introduce themselves and give a bit of background of why they're here. Before we start, though, I wanted to let people know and encourage people to put some questions into the Q&A. So we're going to go through about 20 minutes of discussion, and then we're going to try to address as many people's questions as possible. Okay, so first, Malu.
Hello, everybody. My name is Malu Tansey. I'm a professor of neuroscience and neurology at the University of Florida and the Fitzgerald Institute for Neurodegenerative Disease. And I am very happy to be here. My group works on the role of inflammation and central peripheral crosstalk as a model to understand how the brain stays healthy or doesn't, and how aging affects it, how different exposures affect it, and to identify what kinds of interventions could be leveraged to delay, prevent, or mitigate the effects of Parkinson's. And I'm supposed to tell you a little bit about my background, I think, which is I grew up in West Texas. I went to Stanford, then I went to grad school at UT Southwestern, got my degree in cell physiology, did a postdoc learning all about how GDNF and nurturin could potentiate the survival of dopaminergic neurons, and that's when I got very interested in Parkinson's. Then went to industry for a short time where I learned all about inflammation and TNF. And when I went back to academia, I decided to explore the role of inflammation and specifically TNF in models of neurodegeneration. And that was the beginning of a really fun journey that we're still, blazing that trail, and are super happy that others such as Kirsten and many other labs have joined the fight, because I think there's a lot to be done in this area.
Brilliant. I've learned new things as well. Fantastic, Malu. Okay, Kirsten Scott, please.
Hello, I am a neurologist. So I work as a clinician in Cambridge at Addenbrooke's Hospital, seeing patients with Parkinson's disease and MSA, also some general patients. My main job outside of the clinic is I have recently started working with AstraZeneca on clinical trials in several neurodegenerative diseases. What I'm going to mainly focus on today is my work as an academic. Just before I started at AstraZeneca, working in clinical neurosciences at the University of Cambridge, where I worked with Caroline Williams-Gray on inflammation in Parkinson's disease. So my work focused mainly on B lymphocytes, a type of immune cell, which I'm sure we'll touch on later. But I've also worked with Caroline on a trial looking at inflammation in Parkinson's disease and some other cohort studies, again, also focusing on inflammation.
Brilliant. Thank you. And last but not least, Cure Parkinson's trustee, Alison Anderson.
Hi, thank you. I'm delighted to be here this afternoon. I'm delighted. I can't wait to hear about all of this from Kirsten, Malu, and Thilo. I was diagnosed with Parkinson's nearly a decade ago now, which I can't believe. Time flies past. And I did two things immediately after diagnosis. One was to find out what I could do myself, if there was anything I could do to delay disease progression or slow it down. And I was desperately keen to find out what other people were doing to research what treatments that might slow, stop, or reverse Parkinson's. So I'm delighted that I have other people to answer the inflammation questions. That's certainly not something I'm going to attempt to do, but I'll be interested to listen to it. I was an ambassador last 3 years for the World Parkinson Congress, which brings together people with Parkinson's in the research community. And I think that's vitally important, that we're all working together and learning from each other. in the quest to find a cure. In the meantime, while people are researching and looking for a cure, I'm trying to keep myself as fit as possible so that hopefully if that cure appears sometime in my lifetime, it will be an option for me. So the other panelists in the webinar have a wealth of knowledge and expertise to bring to this discussion, and I've got the lived experience. So hopefully between us, we'll be able to answer your questions.
Great, thank you, Alison. Just before we keep going, there's a comment about the volume being low. So we'll see if that gets rectified from behind the scenes, but I'm hearing everyone quite well. And then also another comment for our panelists, we're going to try to start slowly and then also define a lot of acronyms. So already someone's asked, what does TNF mean? But we're definitely going to explain what TNF means. Okay, so first off, let's ask Malu just for a brief definition of what inflammation is and what's the difference between acute and chronic inflammation.
Yes, thank you for that question. So everybody's very familiar with the fact that in your body, there are cells that keep you healthy from infection. They remove dead cells. So this is the role of your immune system. And your immune system exists in every organ. Think of it as professional vacuum cleaners that dispose of dead cells, dead protein. Your immune system also helps you fight infection. Your immune system takes care of cancerous cells, for instance. And the big difference between inflammation, as most of us think of it, in, say, your arm or your leg, when you stub your toe and you get a wound, right? You have this swelling, you have redness, you have pain, it gets hot. And these are what we call the Celsius signs, right? For Celsius as in the degrees of temperature. And the Celsius signs of inflammation are very common. They're normal. It is meant to mobilize your immune cells to the site of injury to heal the wound and remodel it. And what ends up happening is that after that's done, everything resolves and everything heals. Your cells go back in their cages. And those kinds of inflammatory responses we don't have in the brain. And the reason we don't have those, lots of swelling and lots of redness and pain is because your brain lives inside your skull. And if you had those very marked responses, we would have problems with intracranial pressure. So in your brain, you have a specialized immune system that's composed of what we call brain resident vacuum cleaners, and they're called microglia. So these are very closely related to those cells that do it in your other organs outside your brain. And so there's this communication between those immune cells in the brain and immune cells outside the brain. And this communication is really important for brain health. And so Kirsten's going to explain why not all inflammation is bad and the difference between acute versus chronic. I will step back one more step and say that TNF, which I mentioned in my intro, is one of those inflammatory factors. It stands for tumor necrosis factor. And it's named that way because it was first identified in a tumor. But basically, it's what we call the master regulator pro-inflammatory protein that you've probably heard about within the context of rheumatoid arthritis or inflammatory bowel disease or psoriasis. So a lot of autoimmune conditions and a lot of chronic inflammatory conditions are characterized by high levels of TNF. And as a result, there have been drugs developed to target TNF and specifically blunt its function so that you have less inflammation. And we can talk more about some of those drugs a little bit later. But TNF, along with other proteins called interleukins and chemokines, they are basically proteins produced by your immune system that are used to communicate whether an immune cell has to show up to the site of injury or whether an immune cell is calling other immune cells to the site of where some pathogen has invaded.
Great. Thank you. Thank you. Kirsten, what is the connection between inflammation and Parkinson's, and how do we know, what do we know about it, and what's the connection between the two?
I guess the bottom line is that it's complicated, and that's why we're all trying to understand what the link is. So we know that there is a link between the immune system and Parkinson's disease, and that's been shown on lots of different levels. So if you look at if you take big populations of people with Parkinson's disease and people without Parkinson's disease, and you look at genes that are different between those two groups, and you look at groups of genes, you can find that genes that are involved in signaling between immune cells, there are more of those genes involved in Parkinson's disease than in people who don't have Parkinson's disease. If you look at brains of people or of animals who have types of Parkinson's disease, you can see lots of inflammation in the brain. And people knew that even kind of 40 years ago. People noticed that the microglia that Malu has told us about were kind of activated. They were getting angry at what was going on around them and causing the death of the immune cells. So we knew that those microglia were involved, but 40 or 50 years ago, people thought, well, none of that is relevant. It's just because there's cells dying in the brain. And it was ignored or not kind of focused on for quite a long time. But as we got more and more information from genetic studies and also kind of epidemiological studies, where you look at big populations of people, some of them have been given immune suppressant drugs, some of them haven't. And when we look at those on a big numbers level, people who've had their immune system suppressed are slightly less likely to get Parkinson's disease than people who haven't. And there's important things that we have to think about with, well, what causes what? But that is something that made people start thinking, well, actually, maybe this inflammation is doing something in the disease progression. And the hypothesis that we've had when we've worked on this in Cambridge, and that Malu's group has and many other groups have, is that we know that there's proteins that go wrong in Parkinson's disease, and that those cause death of some of the neurons. And in that process, the activation of the immune cells can cause more damage. And so what we're trying to understand is which parts of the immune system are relevant to that process. So your immune system is, there's cells in your blood, there's all the factors that Malu mentioned that immune cells use to signal to each other, there's different types of immune cell. So the difficulty for us as scientists is trying to work out which bit of all of this do we aim for when we're trying to find a treatment.
Yeah, complicated indeed. Yeah, that was a good explanation. So a very specific question now about leaky gut and inflammatory bowel disease. And there's all this talk about gut-brain axis. What's the connection with leaky gut, inflammation, and Parkinson's?
So we know, again, from looking at big epidemiology studies, that people who have inflammatory bowel disease are about 2.5 times more likely to get Parkinson's disease. So lots of people have thought, well, why is that? And if you look at the genetics of Parkinson's disease, one of the genes called LRRK2, which is involved in the immune system, is also a risk factor for inflammatory bowel disease. So it may be that part of that is because of that genetic link, but even in people who don't have that gene, if you've had inflammatory bowel disease, you're more likely to get Parkinson's disease. And we also know that some of the abnormalities that we see in the brains of people with Parkinson's disease, you also see in the gut. So alpha-synuclein, the protein that gets aggregated in alpha-synuclein and causes damage to neurons, you can find that in the gut. And of course, the gut has a nervous system in it. So it's part of our nervous system and it's connected to the brain. And one of the things that people think is that the inflammation in the gut can either drive or make worse some of this alpha-synuclein aggregation, and that either then results in a spread to the brain, or it increases inflammation in the gut and in the blood that then causes a reaction again in the brain, in it causing the microglia to become activated. I think it's probably fair to say that the exact steps in all of that are a bit unclear, but we do know that there's a relationship between the two, and people with Parkinson's disease know that there's lots of gut symptoms, so probably were telling us that for a long time.
Thank you. Yeah, that was very clear. So what about general infections while you have Parkinson's disease? I think a lot of people with Parkinson's report that it can worsen the symptoms. Maybe Kirsten one more time, and then I'll ask Alison. What's the idea behind getting an infection while at Parkinson's and making the symptoms worse?
Well, that goes back again to what Malu was saying. When you have an infection, if it's a viral infection or a bacterial infection, your immune system gets activated appropriately to try to get rid of the infection. And what that involves is production of these cytokines, the kind of chemicals that the immune cells use to communicate with each other. And neurons don't like those cytokines. So if you put those cytokines directly on neurons in a dish, they die. And so we know that high levels of those cytokines are damaging to neurons, and that also that microglia get activated in the presence of those types of cytokines. And that when that happens to people with Parkinson's disease, they have slightly less reserve, that they're already trying, their brain is working really hard for them to move or talk or do the things that everyone else takes for granted. And having that extra layer of inflammation kind of tips them over the edge where everything suddenly gets worse. Most patients will describe that they then get better after their infection goes away. But that also, I think, gave people reason to think that inflammation could be driving progression, because if you didn't have the kind of driving factor removed, would that just mean that people got worse in the background?
Yeah, I've never thought about that. The cytokines are actually directly hitting the neurons and causing all sorts of problems. Alison, what's your thoughts on this? What's your experience on this?
My experience is quite reassuring, really. Sometimes I feel my symptoms have got worse for no reason at all. And then you realize you're coming in for an infection, a flu, or, something. So sometimes I feel that it's having an impact on me prior to even recognizing that there's an infection about to occur. That would be my observation. But also there's lots of things that vary the symptoms of Parkinson's disease. And it's very hard, even as somebody who's lived with it for a decade, to unpick what's happening. Sleep has an impact. If you're tired, your symptoms tend to be worse. Stress, timing of your medication. There's lots of things that have an impact on Parkinson's. But absolutely, I think most of us with Parkinson's recognize that there's a link between inflammation and symptoms.
Alison, have you ever been asked by your neurologist or consultant about infections, inflammation, and your Parkinson's?
No, I haven't.
Okay, Kirsten, well, what are your thoughts on that? Should neurologists be asking the people they care for about this?
I'm sorry on behalf of all neurologists. Yeah, I mean, I think it's complicated because obviously it's always been what I've been interested in. So I always ask my patients about it because I like to talk about it. In terms of general neurology practice, I think there's most people recognize that infections make all brain disease bad. So that's something that neurologists will know. With MS patients, if they get an infection, it looks like a relapse. Patients with Alzheimer's get worse with an infection. So I think people will understand that as a concept. I think often people don't ask in Parkinson's disease because we don't have a clear intervention that can be put in place, and the evidence base for what you do is a bit less certain. And so people, don't want to recommend treatments or things that haven't kind of been established as kind of standard practice. But I think it's a useful thing to discuss if people are interested or want to bring it up. And most people probably will be able to respond.
Yeah, I agree. Yeah, no, I think it should be on the radar. Okay, so for the next part, we're going to talk about clinical trials. So what's happening now in the US and in the UK. And now I'm going to start with Malu. Can you tell us about TNF again, but the novel approach that you're taking in your clinical trial, please?
Yeah, so as we said, tumor necrosis factor, or TNF, is one of the major inflammatory cytokines that people know about. As Kirsten mentioned, it is present in high abundance in people with autoimmune disorders like rheumatoid arthritis, psoriasis, IBD. And it's kind of a cytokine that destroys tissue and bombards cells with a lot of cell death pathways. And so it's not, soluble TNF is not thought to be, a good actor when it's in high abundance. It does come in two flavors. So there's a form that circulates in your body, and most of that pathology is pro-inflammatory. There's a second form of it, which is actually how it starts out in your cells, and that's that it's attached to the membrane of cells. And when it's attached to the membrane of cells, most of the evidence suggests that form of TNF is really important to help you fight infection and to differentiate and mature the immune system. So one of the things that, Kirsten mentioned is that when you look back at the literature and you see people that have been either receiving a lot of immunosuppressive regimens because they have to, because there's, reasons to do that, or they've been receiving anti-TNF drugs, and the currently marketed drugs are both able to block the membrane and the soluble TNF. Some of those increase your chances for infection, right? And so when you are on these drugs under, IBD or psoriasis or RA, you may see some of the commercials, some of the, black box warnings saying, don't take this drug if you have an active infection, or you may end up with a little bit higher risk for tuberculosis or whatever. So those are the liabilities, I guess, that you put up with, the benefit to risk ratio. Now, when I was in biotech, we happened to stumble upon the idea that if you were to just target soluble, you might be able to spare the membrane-bound biology and not immunosuppress. And we felt that maybe that's a good thing because older people are already, immunosuppressed in some fashion because of their inflammaging and the aging of the immune system. So our approach is to selectively neutralize soluble TNF. And this is a biologic, which means it's a protein drug that is currently in phase 2 clinical trials for Alzheimer's and mild cognitive impairment. It did really well in the phase 1B, which means that it dampened inflammation in the brain by being administered peripherally once a week subcutaneously. And we're very hopeful that very soon, hopefully in the next couple of years, we can do a trial in Parkinson's. Now, in the meantime, there is an ongoing trial that's enrolling for testing anti-TNF, and that's with adalimumab, which is the antibody that exists now, that is being repurposed, if you will, by Jesse Cederbaum and David Hafler in a trial called PRISMS, which is a very fun name. And basically what it stands for is Potential for Rational Immune System Manipulation to Prevent Emergence of Synucleinopathy, PRISMS. And it's a placebo-controlled phase 2 trial that's going to look at inflammation and the T cell function, as well as synuclein seeding in the biofluids. And it's going to look at Parkinson's disease-related patterns of activity, GI and other motor things that you want to look at when you're trying to see if you're slowing down that progression. And it's going to be done in people with RBD or REM behavior disorder, as well as anosmia or loss of sense of smell. So if you want to know more about it, I would Google PRISMS. I believe it's in clinicaltrials.gov, or contact Jesse Cederbaum and David Hafler. We're pretty excited about it because although we believe that it is one way to target TNF, we got to start somewhere, right? And that drug is available already. And I think it will teach us a lot about how inflammation and the things and the pathways that TNF regulates, how that may give us an edge to perhaps slow down or prevent further progression in people who have what we call prodromal or early signs of dysfunction, like REM behavior disorder and anosmia. So that's, I was just in Boston for a clinical trial design for what they call prevention trials for Parkinson's. And the idea is that you can do what we call secondary prevention, which is to take people that are in that premotor stage, right? They only have RBD and anosmia and maybe GI dysfunction, but they don't have tremors or, rigidity, bradykinesia, the cardinal sins that give you your clinical diagnosis for a Parkinson's disease, condition. And by doing secondary prevention, we might be able to, prevent them or slow down their conversion to to more disabling motor symptoms. So that's the idea, and we're very excited about that trial.
Super, super. Thank you. Yeah, the PRISMS trial looks really interesting. I'm going to try to put a link in the chat as Joy is suggesting. Kirsten, can you tell us about some of the work that you've done in Cambridge looking at the immune system in Parkinson's in the clinical trials? Thank you.
So yeah, Caroline Williams-Gray led a trial called the AZA PD trial. So unlike Malu's kind of trial, which is targeting one very specific master cytokine, the AZA PD trial was using azathioprine, which is a kind of very commonly used immunosuppressant drug that many neurologists use for lots of different diseases that involve inflammation. But it's also a very dirty drug in that it targets lots of different aspects of the immune system. It does it mainly by reducing white cells overall, but also acts mainly peripherally. So it doesn't have its effect in the brain, it has its effect in the periphery. And the reason the trial was designed that way was because we wanted to answer the scientific question about whether that inflammation in the peripheral body as opposed to their brain was relevant to disease. So we're hoping that the answer will be yes. We don't have the results from the trial yet, but the trial has been completed now and is in the process of being analyzed. And I guess in terms of the practicalities of azathioprine, the other advantages are if we can show that it's effective, it's a very cheap drug, it's a tablet. We have a lot of experience of using it in elderly populations, so it would be straightforward to translate into clinical practice if it's effective. If it's not effective, then I guess we have lots of questions to ask about which bit of the immune system we target. And we've talked a bit about how the immune system is complicated, and that perhaps kind of using a drug that kind of causes global immunosuppression may not end up being the kind of answer that we have. And even if it does work, it may be that a more targeted drug to one specific pathway is a better option. And which I guess, I don't know if the next question was about the other trials that we've had in Cambridge, but Caroline is also running another trial of a drug that is sort of doing exactly that it's a drug that is targeting, called the Panzer trial, that is funded by Cure Parkinson's Trust and is targeting a much more specific pathway. So it's looking at the activation of what's called the NLRP3 inflammasome, but that's a pathway where the alpha-synuclein activates some receptors on cells, and this is the bit of the immune system that kind of is almost straight downstream of that gets activated. So it has relevance to our understanding of the disease biology, and might work more. Sometimes we find in trials actually that we were totally wrong and that was the wrong way to go, but having a more specific approach sometimes gives a better treatment for the drug. So it may be that something like that, or targeting TNF, is a better idea. But I guess what's important is that these trials happen, because we're not going to find something until we do these experiments in people.
I think that's a key message. The trials really need to happen, and you're starting at sort of a certain level and testing hypotheses, and getting involved in trials is so important. None of this happens without people getting into trials. I'm gonna, actually, let's just do the last bit before we get to the questions. And I'm gonna start with Alison. So what can people with Parkinson's do in their lifestyle to reduce inflammation? So Alison, maybe start with you.
I know that exercise is one of the key things that we can do to delay disease progression. I don't know for sure whether that's linked with inflammation. I don't know whether any of the panel can answer that. But we know that exercise is one of the things that's been shown to delay disease progression. And I think it's really important for people with Parkinson's to take some message about what they can do themselves to have an influence on disease progression, while we wait for research, ultimately to find something that will make a difference to the course of our condition. But yeah, exercise is a big one for me. I discovered early on that exercise was shown to delay disease progression. And in my 40s, as I was at the time, that was a pretty big incentive for me to get off my backside and get exercising and do something. So I got on a bike and started cycling and haven't stopped since. It makes me feel much better. It feels like you're doing something positive. Yeah, so I think it's great if there's something that we know that people with Parkinson's can influence.
Yeah, and you also cycled from England to Barcelona, didn't you?
Did. I was an ambassador for the World Parkinson Congress in Barcelona last year. And I remember in a moment of madness, about 18 months prior to that, saying we could cycle there. And I managed to get a team of 20, 9 of whom have got Parkinson's, to cycle to Barcelona from Brighton, which was 1,500 kilometres. And we had an absolutely fantastic time. It was physically very demanding, but I think we felt better in so many ways for having done quite high levels of exercise every day for a period of time. So
I love it. I remember seeing you there. Yeah. Thank you, Alison. So I think exercise is hugely important. I don't know if you can comment on that, but also people are talking and reading about anti-inflammatory pills, for example, like ibuprofen. Can you comment on that as well as exercise?
Yeah, sure. We think that, we, the experts and people who actually study exercising, the effects of exercise, believe that there's a good amount of data suggesting that it is the best anti-inflammatory you can engage in. I believe it's 20 minutes a day, break a sweat, which means it's different for everybody. And whether it's dancing or vacuuming or running or walking, it doesn't really matter as long as you stay physically active. And there's some really interesting studies showing that the levels of another cytokine called interleukin-6 or IL-6 are inversely related to how fast a person walks, just walks, not runs. But if you are a walker, your levels of IL-6 are pretty low in your bloodstream. And so you're not terribly inflamed. And if you are not a walker or you're very sedentary, the levels of IL-6 in your plasma, in your blood, are pretty high. And that's why exercise trials, one of them is called SPARKS-3, and we can put it in the chat, being done at Northwestern by Dr. Daniel Korkus. They're looking at what are the effects of exercise on Parkinson's progression. It is a huge phase 3 trial, and they're going to be measuring what they call exerkines and inflammatory proteins that are potentially reduced by exercise, or increased if they benefit your your brain and your body health. And so exerkines are kind of a new term for good things that are produced in your body when you're doing exercise. And when it comes to the pill, like we all would love a pill in a bottle, right? Exercise, you got to make time. Most people don't have time, but if you don't make time for it now, then you're going to be making time for your disability much later. And so the problem with ibuprofen and other just standard anti-inflams that you could potentially take is that they are a little bit hard on your gut, on your GI tract. And a lot of people end up with, a lot of discomfort, a lot of, bleeds, and who wants that? So having said that, we are learning from the fact that our society is really good at taking over-the-counter drugs. And when you look at the epidemiology that I believe Kirsten mentioned, and epidemiology just makes an association between some activity or some drug and the incidence of something in a group, right? So it's kind of like caffeine drinkers versus not have more incidence of this versus that. It's an association that's really not meant to imply causation, but it's meant to give you an opportunity to say, are these two related? Are they causally related? And when you look at the ibuprofen data, you see that there are some studies that suggest that people who took ibuprofen chronically for sports injuries, tennis elbow, and they did it early in life because they had to, or else they would have too much inflammation in their bodies, that as a group, they appear to have lower incidence of Parkinson's and dementia. So this is based on millions and millions of medical records. And so you kind of go, oh, well, that's really interesting. But when you look at other studies that suggest, nope, NSAIDs, nonsteroidal anti-inflams like ibuprofen don't have a protective effect, those studies are also interesting because even though it's a negative result, what it's telling us is that those studies are primarily based on people who took their ibuprofen later in life, right before their hip replacement. And that tells us that there's a window of opportunity during which the inflammation really matters. And maybe it does a lot of damage to your body early on, and then it doesn't affect or show up into your brain health for decades later. And so this is why exercise when you're young, good nutrition, sleep, and lowering your stress, the 4 pillars of brain health, are so important when you are young and in midlife. And it's okay if you're past that. It's still going to help you to focus on those 4 things to try to naturally lower the levels of chronic detrimental inflammation in your body.
Great. Great. Thank you so much. Okay, we've got lots of questions piling up. So we're going to try to be concise in answering them so we can get through as many as we can. But I think, Malu, we're going to stick with you. There was a question about adalimumab. Can you answer that?
Adalimumab is the TNF antibody that is being used in the PRISMS trial. So it's an antibody that needs to be infused, and I believe, this is what they're going to test with a placebo-controlled group in people with the REM behavior disorder and the anosmia. It's basically technically a secondary prevention trial that's going to be done.
Okay, so that's clear. So that's all TNF, and it's a repurposed trial.
It's a repurposed drug. I think so. The trade name was called infliximab, and it's basically an antibody against TNF that does not distinguish between the 2 forms. And it's been used for decades and decades for people with IBD and psoriasis and rheumatoid arthritis.
Great, thank you. Okay, so 2 questions about nutrition and inflammation, which is going to be, I think, a very popular question. Maybe, Kirsten, can you speak about diet and inflammatory versus anti-inflammatory diet, maybe?
Yeah, I mean, it's a big zone, and I mean, unfortunately, I think it's also kind of a zone where the evidence is very unclear. And there are lots of kind of companies that want to sell you really complicated tests and kind of dietary interventions that are on shiny websites, and I find that very difficult to buy. So the things that we do know is that having a good diet in Parkinson's disease helps with your overall health. So the things that are really bad in Parkinson's disease are weight loss, and we see that in patients. And when you start to lose weight, you're more vulnerable to infection. You tend to get disease progression. So maintaining your weight with a kind of balanced diet is a good thing. What does that mean? Are there specific foods that you shouldn't eat that are going to make it worse? I mean, I think it's really hard to say. A lot of people will say, well, don't eat inflammatory foods, things that are acidic or that have lots of chili in. And, I think it's really difficult to pin that down and say that that's going to make your Parkinson's disease worse. Stop eating tomatoes. I think it's, when my patients ask about diet, I say, it's mainly what your granny told you, that eating a balanced diet, ensuring you have enough fiber, enough vegetables, you're not just eating hamburgers, that all of that kind of common sense stuff that your granny tells you about diet is the thing that probably makes the biggest difference. And one of the most important things about diet in Parkinson's disease is ensuring enough fiber, because if you get constipated, we know that constipation will affect your absorption of the medication, and that often has knock-on effects. But also Marta Camacho, who's one of the postdocs in Caroline's lab, who I worked with for many years, has done some nice studies showing that constipation also is associated with impaired cognitive function. And there's probably lots of reasons to link the 2. So ensuring that you have enough fiber to keep your bowels opening regularly is probably also kind of good advice. But I think people often want much more complicated kind of information, and I don't think we have the evidence. There's probably some good hypotheses out there, but it's basically what your granny said is the bottom line about what you should do with your diet and fiber.
Yeah, I think, that's a good way of putting it. I think fiber is hugely important. That's one of the messages, if we want to give something a bit simple, is to keep the bowels moving, avoid constipation as much as possible, because that will increase inflammation, not just in your gut, but maybe also in your brain, because of that study linking constipation and cognitive decline. So I'm sorry, Chris, if I ask a bit of specific questions. So people are asking about things like lion's mane, which I think is a fungus, high-grade turmeric, and one other one, cold water therapy. Are these good to reduce inflammation?
I mean, so I don't think we have solid evidence to say anything about turmeric or a lot of the other dietary things. Lion's mane, likewise. Nobody's done a trial to say, is this going to do something? Similarly, I'm a big fan of cold water therapy just because I enjoy swimming in cold water myself. Again, nobody's ever done a trial, and it would be probably too dangerous to put lots of people in cold water. And what would you use as the control group? It's difficult to know. I guess with things like turmeric, it's not going to do harm, mostly, that we know. Things like cold water, I think one has to be a bit careful, because sometimes people do get arrhythmias if you put them in water at 5 degrees. I think sometimes people find, and a lot of people that I have swum with in Cambridge in the river, swear that it really helps their conditions, and that includes lots of things, not just Parkinson's disease. And it's not clear to me what the mechanism for that is. Some of it is actually just being outside and getting some exercise. Some of it is that you get to do something with another group of people and you get a kind of social connection. There's probably lots of factors that make cold water swimming helpful for some people. So I would never tell someone not to do it. But I guess I can't put my hand on my heart and tell you that it's definitely going to work, because we don't know that. But that doesn't mean to say it might not. It's just that we don't have good kind of research studies to tell us that it does work.
Yeah, thank you. Alison, are there any things that you want to comment about diet, or have you tried cold water therapy?
No, it doesn't appeal to me at all, but I know people who do and find benefit from it. I think it's very difficult. I think each of us find things that we feel make us feel better. And whether that's because of the social impact, a physical health benefit, a psychological health benefit, I think there are lots of reasons why it might be. I know that people who feel that they're socially isolated have a worse disease progression than those people who are socially engaged. So finding something that keeps you engaged with the community, with other people, has to be of benefit. And if you can tie that in with exercise and, with a group, then that ticks 2 boxes.
I like that answer. Yeah, social activity, exercise, and cold water therapy, all 3 maybe. There's a really interesting question from Jesse about GLP-1 agonists that I'm going to pass to Malu, please.
Hi, yes, Jessie. Thank you for being here. It was great to see Jessie. She's a person with lived experience in Parkinson's, and she was at the Trial Design Forum in Boston. So her question has to do with the fact that there was a successful exenatide, which is a GLP-1 agonist molecule that most of you probably know through the literature on Ozempic and tirzepatide and Mounjaro and all these drugs that are being used to manage diabetes type 2 and obesity. And so what's really interesting about that trial is that it did seem to afford a little bit of benefit for the progression. And what's interesting is that these drugs don't have a lot of brain penetrance. Some of them have more than others, the class of them. So the hypothesis or the idea is that they're acting by reducing the peripheral inflammation. And it is very possible that to get benefit, you don't have to get these drugs into the brain. And the reason for that is 2 things. We talked about this idea that IBD individuals have an increased risk for Parkinson's. There's also some data that suggests there might be an increased risk for Alzheimer's and dementia. And it's likely to be the fact that, they have chronic gut inflammation. And what happens with chronic gut inflammation is that you erode the barrier that keeps bacteria out of your bloodstream. So the bacteria that live in your lining of your gut, that are necessary to absorb the foods that you eat. Many of them, they're called commensals. They're good, beneficial bacteria. But if you, they're basically staying in the lumen of your gut because the cells of your lining of your gut are very tightly bound together. And what happens is when you eat too much sugar, when you have IBD, when you have maybe different exposures, those adhesions between these cells start to erode. And then the bacterial products from the lumen, from your line, your gut, start to filter through, and they activate the immune cells underneath. And they mount this inflammatory response that eventually gets into your bloodstream, right? So the endotoxin, which is a very, commonly known bacterial product or lipopolysaccharide, circulates in your bloodstream, circulates to your brain, and it erodes a second barrier, and that's your blood-brain barrier. So when you have chronic inflammation, by whatever means it's there, you have the potential to have a leakier blood-brain barrier, which means that stuff is going to go in. Now, we think, this is the hypothesis, that the reason that the anti-TNF drugs, which have been used for decades to treat autoimmune diseases, why they had a potential protective effect may be both because they're lowering peripheral inflammation, but also they may have gotten into the brain a little bit in people that have these conditions, because IBD has a leaky gut, and obesity and hypertension and all sorts of these conditions, you're inflamed, so you're going to have a leakier barrier everywhere. So maybe that was the silver lining, right, of having to take these drugs, and now they're benefiting your brain. But to make the connection is that the GLP-1 agonists, which are not necessarily crossing to great amounts, and there are not that many receptors for them, for the drug to act on them, it is likely that they're going to benefit by lowering the peripheral inflammation. And that is great news. It's great news because a lot of pharma companies have left the CNS space because they can't get the drugs into the brain, right? Well, guess what? They need to come back because now we think these diseases may not start out in the brain, and what happens outside your brain can really influence your risk and your progression.
Yeah, that's really, really important. So thank you for that. There's one question about, are dietitians being used with Parkinson's patients? I think that's a very good question. But I just wanted to make one comment that the Edinburgh Parkinson's lecture this September will be by a dietitian, Rochelle Flanagan. She's an Irish dietitian who has Parkinson's, and she will be speaking about the role of dietitians in helping people with Parkinson's. I think I won't ask anyone about that question. Well, yeah, there's Kirsten. Do you want to answer that? What about the role of dietitians? Do you take advantage of dietitians in Cambridge?
Yeah, we definitely do. So I guess the main reason that I send my patients to a dietitian would be if they're losing weight. So I try to do that early on to prevent, once you start losing weight and you're kind of falling off that curve, it becomes harder and harder to put the weight back on again. So I normally try to send them to a dietitian early, but often a lot of the advice is around giving them support to actually have more calories and eat all the things that most people aren't supposed to eat, like full cream and ice cream, to try and make sure that they're not losing weight. And I guess we probably use dietitians less in giving people advice just about having a healthy diet. I think a lot of the time we as clinicians assume that patients know that, but actually when you ask people, sometimes people are not exactly aware of what a healthy diet is, and they haven't thought about things like their fiber and vegetable intake. And those are pretty basic things that actually dietitians can help with as well. And I guess the other thing that sometimes people struggle with is if they're struggling to use a knife and fork, or they've got problems with their chewing, sometimes it leads to their diet inadvertently being narrowed because they can't cut up the broccoli, or they can't cut up their meat properly. And so sometimes dietitians in collaboration with speech and language therapists are quite helpful to make sure that you've kind of optimized everything, that you can eat it, use the knife and fork, and it's the right textures, and you're still getting every kind of food type. You're getting enough protein, you're getting enough fiber, and sometimes those kind of basic things people haven't thought so much about, and all of that is important.
A quick question. Someone's asking, why is weight loss associated with Parkinson's?
So that's also a really great question. And I think as clinicians, we've always been a bit lazy and thought, well, you have a bit of a tremor, there's a bit more, you're using up some energy, that's why you lose weight. But I think it's more complicated than that. It's not just the tremor, and people who have gait predominant Parkinson's disease also lose weight. And some people really lose weight in a marked rate that it looks almost like they have cancer, and it's nothing except the Parkinson's disease. So the answer is probably complicated. It may affect the lateral hypothalamus in your brain, is involved in regulating food intake, and probably that bit of your brain is affected by Parkinson's disease as well, and that's why you see a change in the weight. It's very, very rare to see people who are overweight with Parkinson's disease. And so often, which suggests to me that they must have had some process going on for some time, because often people say, oh, I used to weigh much more, they lost some weight over time, and then eventually they got diagnosed with Parkinson's disease, and you think in retrospect actually that weight loss was part of their disease.
But often when people get deep brain stimulation, the weight comes back on. So how do you explain that?
How does that work? So again, that makes sense, because those circuits. So I used to teach neuroscience to medical students, and we had to look at all these experiments in mice and rats on which bit of the brain you have to cause problems to cause problems with the eating circuit, and trying to think about, so with DBS, usually the subthalamic nucleus is stimulated, and the circuitry involved in appetite regulation in the brain is quite complicated. So I can't put my finger exactly on how or why DBS affects those circuits, but it wouldn't surprise me that DBS is obviously feeding into one of those circuits, and in the same way that it fixes a lot of the motor problems, it's obviously correcting a kind of error in that circuit involved with appetite regulation and food intake.
Thank you. I think we're getting a bit away from inflammation, but Malu, someone's asking about the 4 pillars of good health. They didn't hear the 4th one: exercise, good nutrition, lower stress, and sleep. Yeah, I thought it was sleep. Yeah, very, very good. So before I start summarizing, Alison, I was going to ask you about these 4 pillars of good health: exercise, good nutrition, lowering stress, and sleep. Which of those 4 are you really focused on, and do you think help you the most?
Exercise definitely helps me the most. That's top of my list. I think sleep, most of us, or most people I know with Parkinson's, have incredible problems with sleep. So no matter what we try, we don't get a decent sleep. So it's quite hard to tick that box in terms of, getting adequate, good quality sleep. But as I've said earlier on, exercise is the thing for me. I think a healthy diet, and Rochelle Flanagan, who you mentioned earlier, was an ambassador for the World Parkinson Congress. I think she also goes by the name the dopamine dunker. So she's big on cold water dunking. So you may want to ask her when she's at your conference about that as well.
Yeah, we will. We'll definitely ask her. Actually, another question has just come in about over-exercise. I've heard this question before, because exercise is good at reducing inflammation, but could you over-exercise and end up losing, even more weight?
Yeah, I'm going to defer to the neurologist on this one, but I'm going to say that it's a little bit of a Goldilocks situation where too much or too little of something is not great for you. There is some association with like ultra marathoners with increased incidence of Parkinson's, and we're like, why does that happen, right? And then we're telling people go exercise. I think there's very big differences between extreme exercise and ultra marathoning and just being physically active, right? Many of the things that ultra marathoners do may be also related to, their different personalities and their different lifestyles and many things that they do differently that may set them apart and maybe put them at increased risk, and including genetics. So it's important to know that, just like too much sleep and, too much exercise and too much, anything is not great for you, everything in moderation. There's, there's something to be said for what's best for you. And the important thing is talk it over with your doctor, ask the questions, be the informed consumer, because physicians don't have time to be up on everything. But if you ask, they will probably read up a little bit on it and be able to have a little bit of a better conversation with you. And I think as a consumer of healthcare, we need to be our own advocates and ask the tough questions. And, knowledge is power. So I encourage all of you to, not just go with what you're being told, but ask the tough questions and question authority.
Great, thank you. So two more brief questions for Kirsten. Can head injuries, either heading a football or boxing, lead to Parkinson's? And the second one, which is quite different, is can type 2 diabetes lead to Parkinson's?
So those are great questions too. I'll start with the head injury one. I think about this often because I have children who play football, and I have started playing football with them, and sometimes we are hit by the ball. So we know in the context of professional football players in the US, but rugby players to a lesser extent in the UK who play these sports professionally and have had multiple head injuries, that is a risk factor for something called traumatic encephalopathy, which looks a bit like Parkinson's disease. When they've done research to try and dig down, what does that mean for everybody else who plays these sports? There's probably a developmental window in children less than kind of 12 or 15, where having repeated head injuries really increases your risk factor for multiple neurodegenerative diseases by quite a lot. But though the degree of those head injuries has to be repeated and over time, and the worst kinds of head injuries are where, particularly in the context of a sport where a child, for example, gets concussed, they go off the pitch for a little bit and then they go back on again and get another head injury in a short space of time, either in a few weeks. And we know that those kind of things are really not good for brain health. Does that mean that you shouldn't play football? Absolutely not. So I think a lot of football in terms of, and football in the UK is soccer. So it's difficult with different audiences. Soccer is the same as football in the UK. Football in the US is, you have to have a helmet and all these other things. But trying to avoid recurrent head injuries, particularly in children and teenagers, is probably a good thing. But the benefits of playing sport, and usually in children's sport, the risk of these kind of things are reduced. As an adult, it also probably shouldn't put you off playing sport, but just to be aware to try to avoid having head injuries for lots of reasons, not just because it might make things worse in the context of PD.
And diabetes, very, very briefly.
Oh yes, diabetes. So there is, again, in the context of the GLP-1 agonist, there is a kind of epidemiological association. If you look at lots of populations with type 2, thousands of people with type 2 diabetes and people without type 2 diabetes, slightly more of the people with type 2 diabetes get Parkinson's disease. And that's on a population level. So with one person, it's difficult to say, and we don't understand why that is. There is a story about kind of chronic inflammation in type 2 diabetes, and with the fact that that's what I'm interested in, that makes me think, that's where the interest is. And that's a lot of what drove the GLP-1 agonist story, that's why people started looking into them in the context of Parkinson's disease. I guess it's less clear in the context of one person, but again, it then brings back kind of sensible things with, if you have type 2 diabetes, to make sure your diabetes is managed, that the blood sugar is controlled, that you're taking care of the other health, to kind of reduce the risk of these other things happening.
Great. Thank you very much. So thank you to all our panelists. I'm going to sum up in 1 minute. So inflammation is hugely important in Parkinson's. So from the genetics and from epidemiology, it seems to be involved in the initiation, but also the progression. So keeping the bad inflammation down is important, and a lot of clinical trials are looking at that. So you can do lots of things on your own, and we've heard that exercise, as Malu said, is the most potent anti-inflammatory pill, quote unquote pill you could take. So if you can do some sort of exercise, get sweaty as many times a week as you can, that's good. That will reduce inflammation. Peripheral inflammation is a big deal as well. So even drugs that reduce inflammation in your gut are important. And diet is also good. And I think one of the messages about diet is that you should eat a well-balanced diet, something that your granny has advised, but getting lots of fiber and clearing your bowels as often as possible. So just allowing constipation to keep continuing is a bad thing for inflammation. And I think that's it. So thank you, Malu, Alison, and Kirsten for a really lively discussion that will be recorded. And this will be available to panelists going forward. And we'll see you at the next session. Thank you.